wanted to talk, obviously today about sleep telemedicine specifically. So, telemedicine is a really broad topic, and Dr. Stroll, we asked me to do one of the grand rounds, and he said, I want you to do X, Y, and Z about sleep telemedicine specifically. So I tried to hone it down to give you guys a little bit of general information and also some more specific, information about sleep, since this is sleep grand rounds. But telemedicine is a very broad topic. And obviously with the pandemic, things have changed a lot. There's been a lot more acceptance about telemedicine, both from the physician side and from the patient side. So obviously, if anybody has any questions like we normally do, be happy to answer them as we're sort of going along here during the lecture. Just want to give a little bit of background about telemedicine. I only went back so far, and I went, telemedicine starts actually BC, so with smoke signals, literally, and visual signals. And there's a little history there that I didn't think was pertinent, but the first use of electronic communications for health purposes was during the American Civil War. I thought this was really interesting that the Union Army used the telegraph to communicate casualty reports, coordinate patient transport, and request medical supplies. So I thought this was pretty interesting. That sort of is the beginning sort of telemedicine in the US. In 1905, Willem Einthoven, who discovered the EKG, actually transmitted heart sounds from a hospital to his lab using the telephone. He called it telecardiography. In 1910, an engineer in England basically used a telephone to transmit sounds of a stethoscope that was from a patient that was miles away. The idea that technology-assisted distance diagnosis, we call that telenosis, and that first appeared in the medical literature in 1948. So this was interesting. This is the first example of radiology using telemedicine. It was between Westchester and Philadelphia, Pennsylvania. So I was born in Philadelphia, and that Westchester is probably about 40 miles away from Philadelphia. So this was pretty groundbreaking in 1948. The first use of interactive video communications was in 1959, and that was at the University of Nebraska. And throughout the lecture, I have all the references are right on the same slide. I changed from my normal format to make it easier for everybody. Also, several years after that, there's a 112-mile closed-circuit TV link that they're between the university and Norfolk State Hospital for psychiatric and neuro consults. And this was a really interesting project. In 1968, Mass General established a telemedicine hookup to Logan Airport, where they would have nurses stationed, and then doctors would be back at Mass General, and then they would treat patients that needed treatment at Logan Airport. The first full-fledged telemedicine network was actually between multiple medical and patient sites in Vermont and New Hampshire in 1968. It was called Interact. They used a two-way television microwave link. So this is really that's sort of the beginning of how we really view what telemedicine is. And then there was another partnership between NASA and Lockheed and the Papago Indians in Arizona, where they use satellite-based telemedicine because of the distance involved. It was a lot easier just to use a satellite hookup to provide medical care for the Indians in Arizona. So just real briefly, telehealth versus telemedicine. Telehealth is actually use of electronic information and communications technology to provide support when distance separates participants. So this can be anything in medicine: lectures, grand rounds. It does include telemedicine, it includes patient care, store forward, home sleep studies, anything that you think of tele use for any device in medicine is under telehealth. Telemedicine is specifically direct patient and provider interactions, whether synchronous or asynchronous, and we're going to talk about that in a second. So just a general term there between telehealth and telemedicine. So when I do telemedicine, like everyone else, to me, the history is no different. So I do neurology, mainly sleep telemedicine. I don't do a lot of neurology, telemedicine. I've tried to avoid that as much as I can as of now. The physical exam is never going to be perfect. Every time I've done telemedicine to Samaritan, there's always what we call a patient presenter, LPN or nurses in the room, and will actually help with the neuro exam. And also, you have to understand, no matter what we do, your exam is going to be limited whenever you're not in front of the patient with direct access to them. There are some really cool device extenders that we can use in sleep medicine, stethoscope, something called the iron bow. I really wanted to set up a demonstration of the iron bow. I don't know if anybody from ENT's on, but from my standpoint, when the nurses turn on the iron bow in the room with the patient, you get a great view of your oral cavity and the tonsils and the palate. It's really clear, and it really allows you to sort of almost be there, at least for that particular part of the exam. So telemedicine is really convenient. It really can be done at almost any place. Patient's home, outpatient setting, place of employment, prisons, something that we don't often think about, but that's believe it or not, is a large amount of telemedicine is done to different prison populations throughout the U.S. The ED squad in Parma, I set up all the ED squads that bring stroke patients to Parma Hospital or to the ER have an iPad in their squad, and they also have a repeater on top of the squad that we added where there was poor cell phone connection. So as soon as they call, what we call a stroke team, they can transmit from their iPad back to the ER, and the ER physician can actually examine the patient while they're in the squad or even in the patient's home. So that's an example, again, of telemedicine that's not related to sleep, but that we're currently doing in the UH system. I don't know that anybody else is doing that in the UH system. Of course, the Cleveland Clinic has what's called the stroke mobile. They actually have a mobile CT scanner that goes around in the ambulance, and then they scan patients and transmit that back to the radiology department. Any medical facility, it's very easy to equip, and we'll talk a little bit about equipment in a minute. Outpatient, inpatient, ER, nursing home. I think while there are telemedicine hookups to nursing homes, that's a really easy and convenient way to take care of nursing home patients. You can be somewhere and round remotely on all your nursing home patients very quickly, of course, with a nurse or LPN pushing your cart around so you can view the patients. Two types of telemedicine, asynchronous versus synchronous. So asynchronous telemedicine is where there's no real-time provision of care. The originating site is where the patient is located, and the distant site is where the clinical evaluator is located. Nurse practitioner, technician, doctor. That's the distant site. Data transmission usually occurs in one direction. So you get data from where the patient is back to the originating site. And originating sites, again, can be anywhere where actually the patient is located. So this is where we have what we call store and forward technologies. So this is like a home sleep study, data from your Cpap machine or cloud-based platforms. So this is where data is generated and transmitted to us for review or whoever's analyzing the data at that point. Also, there's the remote interpretation using sleep medicine with store and forward systems. So this is ultimately what I call a curbside. So basically, all the data is loaded: sleep medicine history, therapeutic and diagnostic data. And then what happens is, after you get all that data, you provide clinical advice via written or electronic report back to the provider. The data stored can include medical records, anatomic findings, sleep data, and PAP device data. So an example would be, say, if a primary care doctor, just forget telemedicine for a second. If a primary care doctor calls you and say, hey, I want to run a case by you. So this is sort of the classic, what I call a curbside, okay? Or other people may say it's a chart review. So this is a way to treat the easy patients, from my standpoint, that don't really even need a consultation. And I think docs do this naturally and have done it all the time. It's just a more formal way to sort of term, what's called a curbside consultation. E-messaging. So we've all started to e-message because the government's mandating this. I actually hate e-messaging. It's the bane of my existence in neurology and sleep medicine. So basically, this is where health providers respond or interact with patients through a secure electronic channel. This is Follow My Health. So I mean, everybody, on the grand rounds today has done this, I'm sure. I think it's cumbersome. I think it's slow, but unfortunately, we have to do it. Usually, they're member initiated and historically have been used for non-urgent, ongoing, or new symptoms. There's a growing body of literature using e-messaging. I think, again, it's easy to do, but it's frustrating from my standpoint. I don't know. At the end of the lecture, somebody can chime in and tell me what they think of e-messaging. This type of care model, basically the patient's got a secure link and can sort of access your email or your tasking almost any time of the day. Self-directed care mechanisms. And these are patients that have direct access to interactive feedback, coaching, or other sleep-related care mechanisms. So examples include, and again, so I'm just thinking mainly of sleep medicine, programs related to cognitive behavioral therapies, optimization of adherence to Cpap, and also smartphone applications for sleep-wake data. So everybody that's sort of done taking care of any sleep patients nowadays, they bring their cell phone in, they have their Fitbit, and they tell you how they're sleeping and what their data is. It's hard to interpret that. It's sort of a poor man's actigraphy, but that's some data that we have from patients in terms of asynchronous telemedicine. So here's the kicker with all the asynchronous telemedicine. How do you get paid for that? The AASM has a great position paper, which I referenced for this paper or for this talk, and they're going to redo that again this year. But basically, they feel that time spent on managing data, quality assurance, and other aspects of care should be paid for. And I actually think, and I totally agree with that. If we're spending time e-messaging, if we're looking over, Cpap data, compliance reports, home sleep studies, I think there's a time component to that, and I think it'd be reasonable to get paid for that. How exactly that's going to happen, we can speculate at the end, but I think that's something that's common and needs to be addressed at least in some way. Synchronous telemedicine. This is the types of telemedicine that sort of we classically, at least that I classically feel is telemedicine. So these are real-time interactions that you have with the patient. They can be via internet, telephone, or clinical video telehealth, or CVT. It's bidirectional communication. It's synchronous, so it's at the same time. And the originating site, of course, can be provider's office, sleep lab, patient's home. As long as it's secure and you can deal with the technical standards of video per second and sound. A distance site can be wherever secure private telecommunications channels are located. And again, these are face-to-face encounters. So at the end, I just want to ask what other people do, but I actually enjoy, this type of telemedicine. The other types of telemedicine, again, it's a little more cumbersome and a lot slower. If you look at the American Telemedicine Association guidelines, I don't want to go over these in detail. Let me make sure I get through my whole lecture. But basically, if you look at minimum live video requirements, is 640 by 480 resolution. So your cable is like 1060. So this is a little. So they're recommending that at least you have sort of minimal cable standards when you're seeing patients over the internet. It's gotten a lot better over time. The resolution with the iron bow is fantastic. So in general, when I'm connected to Samaritan by Cisco, it's fantastic video. Not so much in terms of doxing, and again, that depends a lot on where the patients are, how their internet is, how their internet service is. Okay, and the big thing, of course, always is privacy. So you have to ensure that that at least on your end, you have, encryption for both live and stored information, and that's really important. Most of the time for Doxy, and especially if you use Cisco, that's always HIPAA compliant. So telemedicine feasibility, is it practically feasible? I think it's practically feasible for sure. And I think what's really brought to the forefront is, unfortunately, it took a pandemic to bring, this technology to the public in a much larger way. Sleep disordered breathing telemedicine technology, I think, is pretty straightforward. CVT consoles, standalone high definition cameras, mobile cameras. You have electronic stethoscopes, software, wireless PAP monitoring. All that is sort of already built into our system. I talked with Rebecca Emmons, who's sort of the telemedicine administrative chief, and basically the cost for UH to have telemedicine available for everybody is about $500,000. And I actually think that's a bargain, because that's a lot of providers that can latch onto that platform and have access to telemedicine for millions of patients. Insomnia telemedicine has fewer technical requirements. You only need video teleconferencing, and I think that's pretty straightforward. Web-based programs require only internet access, and again, I think that's pretty straightforward as well. Dr. Stroll also asked about quality metrics. So AASM put out a very nice paper on quality metrics in patients with sleep apnea. So the question is, can you get the quality metrics done using telemedicine? That's the big issue. But I want to briefly review what the quality metrics were. They selected 3 outcomes: improved disease detection and categorization, improved quality of life, and in reduction of cardiovascular risk. They chose 10 processes: improved disease detection and categorization with baseline assessment of sleep apnea and severity assessment at initial diagnosis; improved quality of life, evidence-based therapy prescription, assessment of adherence to PAP therapy, to whatever sleep therapy you're using, assessment of sleepiness, and assessment of motor vehicle crashes or near misses, and then reduction of cardiovascular risk, assessment of weight management, blood pressure, and elevated blood pressure discussion. I think as sleep docs, we do all these naturally every time patients come into the office. I think they're straightforward. Sometimes they're difficult. Sometimes it's difficult to treat sleep patients, but I think all the quality metrics that are stated, I think we do on a very consistent basis. So AASM also felt that you can have a comprehensive, telemedicine program with home sleep study, wireless PAP monitoring, and then provisions for follow-up care. And I think that will take care of a lot of patients. It certainly doesn't treat all the patients that have sleep apnea. There's certain things you can't do from a telemedicine standpoint, but I think a majority of the patients you could take care of easily using telemedicine. Economics. So I think there are some startup costs to doing telemedicine, and also sort of continual costs that we'll have to talk about. One, you need like a telemedicine cart. And again, I think $500,000 for the whole system, I think, is pretty inexpensive given the number of DOT providers and patients that will be linked to it. Usually you have this at the originating site. There are some fees for space at that site. Obviously, with a large system, things are sort of, cooked into that system. It has to be HIPAA compliant. I don't think there's any issue at this point. Cisco Jabber is a great platform for audio and video. It's fantastic, and it's available to obviously everybody in the UH system. The real interesting thing about the store forward systems, there's only 2 states where the government will pay for store forward care or asynchronous telehealth. That's Hawaii and Alaska. So in those 2 states, you can be discussing over the internet and do your care that's not real time. There's also state-by-state licensing and malpractice insurance. Most malpractices are covering, your telehealth visits. Patients still have a hospital copay, and a visit copay, and then hospital facility fees are still around. It's for the 2 places that we do telehealth in the UH system that are not related to COVID. So these are places where, they're We've been doing them before. Your hospital facility fee, which is not attached to the doctor, is $168, and the insurances have all been covering that. So if you're in Conneaut or you're in Ashland, the insurances have been paying for your hospital facility fees. So this is my billing, and it's everyone else's, I assume. I got this from our financial person. It took me months to try to pull this out. I don't know why it took so long, but basically, just a comparison between commercial and government pay, non-telehealth, and telehealth visits. And you can see, if you look at the new visits for non-telehealth versus telehealth commercial, it's about $23 less. And also it's $160, and I think it's $73 for the telehealth visit for the government. So I think the reimbursement rates are pretty reasonable. You'd like to think that telemedicine costs are a little bit less than paying for billings. Most of a lot of telemedicine visits are done from doctors' homes or places that may not cost as much as having dedicated space in a hospital system. But I think clearly everybody's paying at this point. And I think what's going to happen is, I've talked to a lot of people, the feeling is that they're going to keep telemedicine reimbursement where it is, and they're not going to drop it compared to in-person visits. Again, and I think it took a pandemic to make that happen. We'll have to wait and see what the government does in terms of that. Telemedicine liability and licensing, pretty straightforward. American College of Physicians. Basically, if you're going to do telehealth, make sure that your insurance, your malpractice insurance covers it. You have to have documentation at each originating site. So everywhere you're doing telemedicine from, you have to make sure that you're going to be covered. Ensure all data recording and storage regulations are followed. Again, it's just as if you're doing face-to-face visits. One other interesting thing, there's something called the Interstate Medical Licensure Telemedicine Compact. That is now approved in 29 states. So every state has legislation for this. And basically what it is it's a way that states can allow telemedicine to occur from one state to another. And it's easier for the physicians to get licensed to do that. You still need a license in that state, in one of the originating states, but then all the other states are probably going to be covered over time. I don't know why any state wouldn't do that. Ohio is not one of the 29 states. They're on the slow side in terms of allowing people to do telemedicine to Ohio. But the other states are much more likely to allow you to have coverage in their state from outside the state. So I want to go over a couple studies for telemedicine for sleep apnea. Basically, the first study is telemedicine is going to allows greater access to care. The study is going to compare patient satisfaction and CPAP adherence by patients that are seen in person versus video conferencing. So took new patients via video or in person. We did they did a satisfaction score and CPAP adherence. And they looked at the percentage of CPAP that was used greater than 4 hours. And then over 2 consecutive weeks that was compared. And basically what they had is mean scores in person. They had 14.2. This is the patient satisfaction scores versus 14.91. So there was no difference in the patient satisfaction scores. And the mean percentage of nights where CPAP was used, there was not any difference between the groups. The conclusions were basically CPAP treatment, they were compliant and they were satisfied with their care. And it looked like video conferencing may improve access to patient care without sacrificing treatment, adherence or satisfaction of their care. OSA with web-based programs, basically we looked at, can you have PAP adherence? Can it be proved with telemedicine monitoring? So we did a single center when they looked at standard CPAP treatment versus PAP treatment with a telemedicine monitoring system. So this was an interesting study, and this was from Canada. And basically what they looked at, patients were randomized either to standard care with just like an auto PAP, or they took an auto PAP machine that transmitted physiologic information daily and could be reviewed. So, and they looked at PAP adherence after 3 months, sleep quality, and side effects. And basically, they enrolled 75 patients, and after 3 months, the PAP adherence was greater in the telemedicine arm versus the standard arm. And when PAP was used, they had 321 minutes versus 207 minutes in the standard arm, and on average, and this is the other issue with this study, is that it required a technician to monitor patients' PAP adherence. So this required extra money and extra system time to make sure patients were using their CPAP. But the bottom line is, using a web-based telemedicine system that, versus just regular follow-up like we all do, patients did a little bit better. So whether they were reminded by their sleep technician that was following them, whether that helped them do it or they just did it on their own, it's hard to say at this point. Okay. Another web-based program, this study looked at Cpap and client satisfaction, and they were randomized to telemedicine supported traditional care. This was a university setting. Patients were randomized to telemedicine support or traditional follow-up. This is the telemedicine group basically received what's called a health buddy computer, and this provided feedback from their nightly CPAP usage. At 30 days, there was no difference between the CPAP groups receiving traditional care versus telemedicine. No significant difference were found in functional status or client satisfaction. So I think this study is really interesting because it's something that replaced a person. So these people were looking at this health buddy computer, and they were, interacting with this computer and weren't even interacting with people. So I thought that was pretty interesting. It's almost like you had somebody just reminding you to use your CPAP and then telling you how well you were doing with your CPAP on a daily basis, and it didn't require any input from people versus the traditional method. So it's a little scary because I don't want to be replaced anytime soon, and that's a little bit about what this suggests. So it's almost like a doctor robot, if you will, that was helping patients use their CPAP and ensuring that they were using it on a consistent basis. I thought that was another interesting study. I think this next study is
John, previous study, they talk about times in which they could have to break out of that health buddy model for either odd questions or other things. Because I would think that there would be a role for expertise. That doesn't mean you're not going to be replaced, but you could take care of more patients, but because of those more patients, you'd still have interactions that would be valuable.
Sure. I don't know if in the research, at least, whether they were allowed to pop out of that or not. Obviously in the real world, there's still some doctor that's going to be, or healthcare provider that's going to be attached to that patient, where they would, have higher level questions, because the computer might not have all the answers. Is your point? At some point, you're going to need to have a doctor or a nurse practitioner or a PA attached to that patient, address higher level questions, which is very reasonable. I'm not sure how they did that in that study. I'll be honest with you. I'm not sure what they did. That's a great point.
Kaiser's model is that they take care of 350,000 covered lives with 1.5 sleep specialists.
No, that's
their tele extenders and computers and things of that
right. That's pretty amazing. I have to admit, even though I do a lot of telemedicine, as I was, preparing for the lecture and doing the research for the grand rounds this morning, I was just blown away at the different ways that have already been done. And we're talking anywhere from 5 to 10 years ago, where people, made these different models, and all the models were not, there wasn't one inferior model that was done. And I thought that was just amazing to me. I mean, because I'm a very traditional doc. I see my patients, take the history, do the physical, write the orders, and all the studies that I've gone over, didn't have as much time to go into a lot more details, but it's amazing all the different ways that work. That's what's totally amazing to me. Really incredible. The next trial was a pilot study. They showed that they basically did telemetrically triggered interventions associated with CPAP. So they had symptomatic patients were randomized to either a telemedicine arm or a control arm initiated CPAP treatment. Now, this is interesting. So they had phone calls that were triggered in the telemedicine group during the first month of treatment if the patients weren't using it or if they had mass leakage. And then they looked at patients that were followed for 6 months, and then they looked at how much CPAP, how often they use their CPAP. They enrolled 240 patients. 30% discontinued their CPAP over the course of the study. The primary outcome was proportion of nights with CPAP use greater than an hour. It wasn't different in the telemedicine versus a control group. The daily usage of CPAP at 6 months didn't make a difference. And then, but in a post hoc analysis, telemedicine led to increased device use in a subgroup of patients with mild disease. So this study basically, when you had sort of automatically triggered interventions, it didn't improve CPAP use in the study population overall. So this is the one trial where you had sort of a robot, a telemedicine robot watching over you that didn't improve your CPAP adherence. Another automated telemedicine intervention, and this was a 4-arm randomized trial. They randomized almost 1,500 patients. And patients had home sleep testing, and about 556 were prescribed CPAP. There were 2 telemedicine interventions. One was a web-based sleep apnea intervention called Tele, and then there was CPAP telemonitoring with automated patient feedback. So they randomized to 4 groups: usual care, Tele added, Tel-TM added, and then both. And the primary endpoint was CPAP usage. Secondary endpoints were OSA eval and also Epworth Sleepiness Scale score. So if you look at the if you look at the results, if you look at usual care, which is 3.8 hours versus both the Tele both groups 4.8, basically there was significantly higher usage when you had sort of reminders over the internet. Medical adherence was pretty significantly improved from 53% to 73.2%. So basically, this CPAP telemonitoring with automatic feedback improved 90-day adherence in patients with sleep apnea. I have really no idea how to go about doing this. I'd have to get more of the methodology from the paper. I don't know how even we would do this in our system. I'm assuming Kaiser has however they're taking care of 350,000 covered lives with 1.5 sleep docs. Somehow they're using automated PAP monitoring to be able to do that, because I mean, I have enough trouble just taking care of all of my patients with CPAP and troubleshooting and following their compliance reports. I'm not sure. I don't even know where we would start within the system here. I really don't.
Yeah, this is the Kaiser.
Yeah, I mean, it's pretty amazing. I mean, I'm pretty blown away that so much is automated and so much of human interaction is replaceable. And again, my sense of telemedicine is that I'm always talking to the patient. I'm the man, not the computer is the man. So it's again a totally as a real eye opener for me in terms of different patient care models that people are already using, that sort of push me aside to some extent. A couple more studies. I want to see should have good amount of time left. There's another study looked at an automated telemedicine intervention to improve CPAP. Basically, they took 250 patients with CPAP, and this is really interesting. They used a theory-driven interactive voice response system. So basically, you're on a telephone and you're interacting with an automated person, just like you do when you call Apple, when you call a lot of companies now, and it drives you down a menu to what you need to do. And basically these, what's the TLC CPAP monitors, they're self-reported patient behavior, CPAP-related symptoms. And then they had a sleep symptoms checklist, functional outcomes, a sleep questionnaire, Centers for Epidemiological Studies Depression Scale, and the Psychomotor Vigilance Testing. And they used this, they checked the hours of CPAP usage and effective mass pressure stored in the memory and retrieved at each visit. When they used this TLC CPAP system, they used the CPAP for an hour a night more than in the control subjects at 6 months, and 2 hours a night at 12 months. And that's pretty significant, you know, from my standpoint, in terms of taking care of patients that have sleep apnea. In the secondary analysis, adherence on the effect of CPAP adherence was analyzed, and basically had a greater reduction in sleep symptoms and depressive symptoms, and didn't make a difference in, there's no observed difference with reaction time. So basically, what's really interesting is, again, this is a sort of an automated system that improves CPAP compliance, and with improved functional status and decreased depressive symptoms. This is I think this is our last sleep apnea using smartphone applications. Basically, what they looked at is the multi-center randomized control trial that compared standard CPAP care and CPAP and a telemedicine intervention. They had 107 patients with 107 sleep apnea patients. They're randomized to standard care or CPAP and telemedicine. And patients were assigned to telemedicine or equipped with a smartphone. And what they did was they uploaded their blood pressure measurements daily, CPAP adherence, sleepiness, and quality of life data. And basically, they received what's called pictograms containing health-related messages. Main outcome was a home self-measured blood pressure, and the secondary outcomes were noted as well. Basically, the self-measured blood pressure did not improve, and so they were looking to see if they could drop their blood pressures just using sort of CPAP compliance with their smartphone, and it didn't make a difference in terms of their blood pressure. And basically, patients did better with just going to family doc and getting their blood pressure treated. Telemedicine for insomnia. The AAM task force, and they're coming out, I think, with another position paper either this year or next year. Basically, they endorse live interactive telemedicine for care for insomnia patients, including sedatives, stimulant medications, wake promoting medications, and other controlled substances. In Ohio, the real rule is that you have to see every patient that you're giving a controlled substance at least once a year in person, and the rest is telemedicine. So you can do 1 time in person, and then 3 times you can do via telemedicine. Other studies for insomnia. One of the studies, they looked to do a novel web-based CBT course delivered by an automated virtual therapist compared to a credible placebo. And basically what they did is they randomized a placebo-controlled trial, CBT, image relief therapy, and treatment as usual. And basically they had, for the CBT and IRT, they had 6 online sessions delivered by an animated personal therapist. So this wasn't a human. They had automated web and email support. Online CBT users had social network and community users, and TAL comprised no restrictions on usual care. Basically, those patients did whatever they wanted. Primary endpoint was sleep efficiency. Online CBT was associated with sustained improvement relative to the TAL and the IRT groups. So I thought this was interesting that CBT delivered by sort of a virtual therapist with automated support improved insomnia patients. And again, I wouldn't even know really where to start to be able to get the virtual therapist. I'd be happy if my patients would see Dr. Ahmed over the internet to get their CBT. That would be fine with me. There's some resistance even to that from the patients, let alone being involved in a trial such as this. Another study compared internet-delivered group-delivered cognitive behavioral therapy for insomnia. Basically, investigators conducted 8-week randomized trial, had 6 months follow-up. Primary outcome measure was insomnia severity index. Secondary outcome measures, sleep diary, depression, and response and remission rates. Both treatment groups showed significant improvement in terms of their insomnia scale. And their, let's see, Confidence interval between the post-treatment groups and a 6-month follow-up indicated non-inferiority of the CBTs despite which way that it was done. Basically, your internet-guided group CBT were pretty much similar in terms of their ability to treat insomnia patients. I want to talk a little bit about logistics of telemedicine. And again, at the end, I'd like to garner some comments from everybody else to see what their experience has been, if they've had an experience. I think there's a lot of advantages for patients. One is access. Some patients, are so far away from docs or hospitals or care that they cannot access subspecialty or specialty or even primary care. There's really no waiting. You could be at home and doing your chores and waiting until the doctor calls. I think today's an example of inclement weather. If it's hard to get somewhere, geographical convenience. If you're in Manhattan and you need to get to the doctor, it's going to take you just as long as if you lived in a rural setting and had to drive many miles. I think one that's really interesting, there's minimal travel for patients or caretakers to that matter. A lot of neurology patients I see are demented and they can't go to their appointments alone. They need to have somebody take them to the appointment, which means their caretakers have to take time off from work and then drive them. There's minimal travel for providers. If you're doing your telemedicine at home or if in your office, you don't have to get in your car and spend some window time getting to other places. Expanded time slots. So as time goes by, it may be that you offer telemedicine at 6 a.m. or as late as 11 p.m. People work different shifts. People have other responsibilities, jobs, taking care of their children, and may need to have some time slots that are not traditional within doctors' offices. There's no need to leave work. You can be at work, go into your telemedicine room, and have your appointment with your doctor. There's no need to leave the nursing home. This is already being done. This is not anything that's unusual. I don't think there's a large presence that UH has in terms of telemedicine at nursing homes. I think other systems do. You can, for simple follow-ups, you can have multiple providers available. And the other thing that's interesting for us is you can view the patient's home environment. From a sleep physician standpoint, is there a lot of road noise? Are they near an interstate? And you can look around at the house and see, do they have a lot of pets? Do they have a lot of kids? I mean, what else is going on in their environment that you don't get to see when they come in to see you in the office? Economic advantages of telemedicine. I think there's going to be a little bit lower cost for providers. And again, that all depends on how the government shakes out and where you can do telemedicine from in the long term. You might need lower rent, you might need less office space. So when we're doing telemedicine, there may be no one in the office and all the coordination of care and getting patients on your various telemedicine platforms occurs from my MA's house. She's sitting in her house and calling patients and getting patients ready for me to see them. Fewer devices. There's no loss of waiting time in the office. There's no travel. We talked about that before. Limited ambulance rides. And this may not necessarily apply to sleep medicine, but for a lot of my neurology patients that have mobility issues or in a nursing home, they're transported by ambulance, which is like a $300 ride, to and from my office building. And if you had telemedicine to that nursing home, that would save $300 for the system. And over the course of time, that's a lot of money that the system would save by not having just ambulance rides alone. Limited no-shows. So, there's very few people that don't show for their telemedicine appointment. They're sitting at home or they're going to an office. I think there's more no-shows for patients that are in person and have to travel to get to the office. Online scheduling. And the next thing really that I think is going to really help telemedicine become more efficient is online patient intake. Like patients are going to actually be putting all their medicines in, all their medical histories, and it's going to be checked by your MA as opposed to, patients, giving the MA the intake where it takes like 20 minutes to do once they get to the office. Telemedicine needs. I think the biggest telemedicine need was met. It was the global pandemic that occurred. And I think this, more than anything that could have happened, brought home the need to have a robust telemedicine system. I was doing telemedicine before the pandemic hit and doing it basically to places that didn't have subspecialty care. But I think with the global pandemic, people are going to see that it's just a lot more convenient to do telemedicine where you are. Insurance rule changes. Hopefully, the insurance and government rule changes will allow telemedicine to sort of flourish from an economic standpoint. I think that's really going to be the issue. Is there going to be increased reimbursement, or at least stable reimbursement compared to in-person visits? I think that's going to hopefully toe the line over the next year or so, and we'll see where that all goes. Virtual hospitals. So I think the next thing that's going to happen is, instead of patients coming to the hospital, we're going to take the care to the patients. Care in homes, nursing homes. We already do a large portion of this. This is not new. It's not something that hasn't happened. What I think is going to happen is that you're going to actually take medical care to the patients acutely. So we already have mobile CT scanners, mobile MRI scanners. And what a lot of hospital systems have done is, with COVID, they've given patients an oxygen monitor, a heart rate monitor, and then they're monitoring the patients while they're at home. And I think what you're going to see is this is going to become a more commonplace issue, as opposed to patients actually coming into the hospital. As devices get slicker, smaller, and more mobile, you're going to see a lot more people being cared for in their homes acutely, as opposed to coming into the hospital. And I don't have anything else to say other than that. I just feel that that's where this is going to go. So doctors started making house calls, thousands of years ago, and basically we're going to be doing it on a grander scale for patients that are a lot sicker in the future. Okay, conclusion. So I think over the course of the last year, I think telemedicine in multiple forms is medically, economic, and logistically possible. Is it perfect? I would much rather see patients in person. I think that I enjoy it more. I think the patients enjoy it more. Over the last year, it's been really difficult because we just haven't been able to do it from a global pandemic standpoint. Telemedicine is applicable to almost all medical subspecialties. I can tell you it works great with sleep medicine. Sleep medicine is much easier than neurology. Neurology, you miss a large portion of your exam. Even though 90% of your neurological diagnosis is from your history, there's still a component of patients that I need to examine before I can make any sort of judgment about what to do or what the diagnosis is. We're already doing surgeries remotely. That's not something that's new. That may become more widespread. Research on a lot of levels is easier to do, and you can see, based on some of the studies that I reviewed. Again, I was very surprised at all the different ways that people have looked at telemedicine use, asynchronous, synchronous, for care of patients that have sleep disorders. It's pretty striking. What I didn't see a lot of patients that had narcolepsy with this, but you would think that, again, most of your care for patients with narcolepsy comes from history, and that this would be easy to do from a large-scale telemedicine component. International care. So there are companies that are starting to do international care. For instance, some countries on different continents may require subspecialty care that isn't available in that particular country, and also super subspecialty care. So the way I see that working is, you may have, experienced sleep physician that does a lot of work, and they get a lot of store and forward information from different doctors, different physician extenders. And basically, it's the way that anesthesia works. Anesthesia has one anesthesiologist, and they monitor five nurse anesthetists. And that's basically, what's going to happen. I think with sleep telemedicine, you're going to have the Kaiser model, and it's going to be where you have a couple docs taking care of a whole bunch of patient lives with any sleep disorder. And that's one way in which your shortage of sleep care is going to be cured. Is it when you can take care of patients in different ways? I think the big issue is, how do you get paid for doing that? So that's an important long-term issue. So I was just be curious from the audience how you viewed your telemedicine experience over the last year, if you had one at all. And if you didn't have one, is it anything you'd be interested in doing? Because, I think UH has, has a unique ability to sort of reach out to a lot of patients, not only in its system, but outside the system to provide telemedicine services for sleep. Not to mention, again, I didn't even talk about other telemedicine, telemedicine and other subspecialties, because each of those is its own separate lecture. But I'd like to hear from some of the people that are listening today, what were there, how did they feel about telemedicine, and it's something they would be interested in. Kingman, have you done any telemedicine for the VA?
Yeah, oh yeah. VA is, and they have this thing called the virtual patient. And it's okay. It's a little clunky, but when it works, it works. And it's actually, I think that might be, I like it better than DoxyMe. I think the ability to get on and make a visit like you would a house call is going to be coming. So my question really is, do certain patients or certain situations, do they kind of come to telemedicine? I'm thinking about the ones that didn't have had very little interaction with people. If self-efficacy and self-interest in terms of being treated is sort of a self-selected group in those studies, I'd be interested in some of the psychologists that do the insomnia work, because that seems to be that to me would be really how do you interact? Are there certain sorts of doctors and patients that kind of do that best? That's, I guess, my question.
Yeah, I think you have to. I think in general the people that use telehealth tend to be on the younger side. The people that, for instance, if you're older, then you're going to need help just getting on your iPhone, and I see that a lot when I do my telehealth visits. I think over time, what's going to happen is that so much of life is virtual, that I think that person is just going to be everybody. And I think I actually call it transgenerational change. As one generation moves out, for instance, again, looking at all these sleep apnea studies and how there was self-monitoring done, I never could have imagined that, say, 25 years ago. I never would have thought that you can go to a website or press a telephone and it would tell you what to do. I mean, I never thought that would be the case. I always thought you would go to the doctor and the doctor and you would talk about things and he would tell you what to do. He or she would tell you what to do. And it's just surprising to me. So I guess my point is, over time, if there are people that can't use a telephone or an iPad or a computer, that's going to go away. And everybody is going to, that's just how life's going to be. Humans are going to adapt to a more virtual environment, and everyone is going to do this. That's what's going to happen.
It's sort of quaint how we do it now. Huh?
It is. It's again, it's very striking to me. And even looking back on the history of telemedicine, I think what's limited the growth of telemedicine is just money. Yeah. It's money, and I know that in terms of the VA, they have a fantastic telemedicine system compared to the rest of us. I mean, they really do. They do. My dad is a veteran, and he had ENT, primary care. I mean, basically, and the ENT was in Texas when he had his issues. It was just pretty striking to see, that happen. Of course, my sister had to help him with his cell phone, but that's another issue.
Morning, guys. This is Samina.
How are you?
Good. How are you doing?
Good.
I was just going to comment. So One of the things that I liked about the telemedicine service, especially through the VA when I did all my training there, was it also allowed us to create additional services. So I remember working in a weight loss clinic, and we would do support groups through telemedicine in rural settings. So I actually, working out of Chicago, I saw patients down even in Kansas and Missouri. And what they would do is actually show up to their local CBOC or community VA center and sit in a room. And then the nurses or the MAs would come in, turn on the telemedicine system and walk away. And I was able to reach maybe 50, 60 people at a time, all through the telemedicine service, all around the region, which I thought was nice because this is something otherwise we don't get to manage in person. And then the support group was that much more effective, where more and more people were inclined to come and gain something out of the experience without really having to participate as actively as you would in a smaller setting. And then even in my clinic now, what's been nice is I'm actually reaching over to the west side through telemedicine. And so I'm capturing a lot more patients and a different type of population. I've seen a lot of 9-to-5 office workers that typically just didn't have the time to see me and would not take the time off to come in and see me. So during their lunch breaks, during their 1 hour breaks at any point in the day, they would log on and meet with me. Oftentimes they're eating their lunch, but the session worked out just fine since they tended to be higher achieving and more functional with telemedicine, with internet services to begin with. That, and then residents was the other one. I saw a lot of medical residents over the past year because they're just stepping away from their clinic duties for a brief period of time to meet with me. And I feel like these are two populations, you know, the higher achieving corporate workers as well as the residents that need treatment, but haven't been able to get it otherwise because of the demands of their jobs. So it's opening new services. It's also opening new patient populations to come in and get the treatment. The only problem is I wasn't able to get the proper compensation before this year. We just didn't get paid well enough for psychological telemedicine services. For the VA, it didn't matter so much, but in academic medical centers, you know, the dollar amount counted, and that's why I'm doing much better this year than I have in the past with that service.
Why is that? Why is that?
The insurance policies changed. They were willing to compensate as they are for in-person visits for telemedicine services for the pandemic.
So that's actually a fantastic story. I mean, that's, you know, and I've tried, like, from my Samaritan clinic to send you a lot of patients, and because I figured that would be that's, you know, CBT is just a great service for telemedicine. I mean, that fits like a glove. I mean, that really is amazing. And I agree with you. That's why I sort of ended, you know, it's the economics of the insurance companies and the government that has limited the spread of telemedicine. I mean, it's clear about that. The VA is a little bit of a different story because it's funded and, you know, they get to do what they want and can make changes quickly. But your story is a fantastic story. So, for instance, that's something I think in terms of, you know, our sleep letter, that's something I would advertise the heck out of, because that's a service that's unique and it's convenient and it's going to make a huge difference for people. You know, if I could do that, that's a fantastic telemedicine story to tell. It really is. I mean, matter of fact, I think Kelly, I should mention to Kelly, you should mention to Kelly, say, hey, I think you need to do a little article on this, because that is huge in terms of telemedicine. That really fits right in line with all the studies I reviewed and really modernizing the practice of medicine. That's what it is.
You know, I think I'd like to have more, you know, it doesn't have to be grand rounds, but somehow get you and Samina as a kind of the co-chairs of our telemedicine outreach, because it's not just to the people that are high achievers. It's also to East Cleveland. It's also to other areas. And we just need to have you two and economics people around to sort of say, how do we structure this that
are there any, I'm sorry.
No, that's it.
Are there anybody else? I mean, that's it, like that, you know, Dr. Med's story is fantastic. Is anybody else, I'm just curious as to anybody else's experience with telemedicine, because everybody's done a little telemedicine with the pandemic, every physician.
Yeah, this is Christy. I would say that we've seen a similar thing in terms of the referrals that I make to Carolyn Landis on the PEDS side for CBT. That families seem much more willing when I tell them, you know, she's doing everything virtually. It seems to be a much easier sell to get them to actually follow through on it. That's anecdotal. I haven't actually looked at, you know, I don't know how easy it would be to look at data, but it seems like people are following through to a much higher degree. And also in follow-ups with us to review sleep study results and for medication management, our follow-up rates seem to be much better using telemedicine.
I agree, because like I said, I see there's very few people that don't show up for their telemedicine appointment, because if they're at home, they just turn on their phone, their iPad, or their computer, and they're good to go. And I think not only from a sleep standpoint, but I think UH as a whole should, you know, and I know they're investing in some more infrastructure for telemedicine, but you also have to let the patients know, hey, this is available for you if you want. And maybe they do telemedicine 25% of the time as opposed to 0. But my hope is that the government and the insurance companies see the value of telemedicine, not only for patients, but also for providers. Because we'll, you know, I mean, both of the things that you guys mentioned now, I mean, those services, maybe those patients never reach a provider. But with telemedicine, it's easy to reach providers. And I think those are great stories. And I really think we need to advertise that, and they should do, you know, a whole section on that. That's something that's brand new and groundbreaking from my standpoint.
John, this is an excellent talk. Thank you. Very comprehensive. And I agree with all the comments. I absolutely love telemedicine. It's just, we've seen so many people from so many different areas that would have not otherwise come to us. My only concern is this very small population that we're not seeing in the literature. And this is the disadvantaged group, the ones who don't have the Wi-Fi and all these. Early on, we saw this in the pandemic. I treat a lot of children in disadvantaged households, and we often revert to telephone. So I wonder what your thoughts are on that. And the telephone reimbursement is quite dismal. I think we've gotten like $0 and for some of the phone calls, but it's providing some care. So I love your thoughts on that.
So I think those are two good points. One, in terms of the disadvantage, I think, you know, if I think what we should do is, you know, while we've had the pandemic and, you know, to really help people out, you can always, you know, the government and the insurance companies are stuck with me being at a specific spot to get my medical care. Why can't we have a room in a public library? Why can't we can have other telemedicine rooms that have nothing to do with UH, with, you know, a UH, you know, building. So telemedicine can occur anywhere, and that's the whole point. So if you're seeing a disadvantaged person, can they go to the local library? Can we have spots at public housing that is a telemedicine room and is not even it's not even for a specific organization. Could be for the clinic, Metro, UH, you know, Gnomes. It could be anybody could use that room. And these are the sorts of changes that the government's got to say, you know, hey, in order to make it convenient for disadvantaged to get medical care, this is what we're going to do. And I think that's a great point. In terms of the telephone coverage, I agree with you. It's a lot less. Sometimes I just can't get a connection on Doxy. I can't get a connection on another platform, and I'm stuck. And it's a narcolepsy patient, and I'm hoping that over time, as people become better at using telemedicine, you won't ever have to use a telephone. You just use your Android or your Apple device, and you get connected that way.
Yeah, I love the idea about using like a public
Absolutely.
library or something like that.
It's all up to the government.
Future.
Yeah, it's for the government to make that change. And why not? Just carve out a little telemedicine room. All the libraries have Wi-Fi and great internet connections, right? And that'd be a perfect place to put that.
Great, thank you.
I wonder who we could push to do that as a demonstration project. Where would you want to put it, Sally?
Well, I guess we'd go by zip code, lower socioeconomic groups notoriously have poor sleep in general. And then I've just anecdotally seen that they just have poorer connections. They, we have to work as care clinicians much harder to connect with them. And I don't want to give up on those families. It's a lot harder to connect with them.
Yes, but Cleveland has what they call, I'm aware of the Settlement House on 55th Street, and they have 23 neighborhood health systems that usually do things like food and transport to things. I wonder if we could partner with those people. I think the CTSC would be able to provide some and do a demonstration project. The University Settlement
Sure.
is one of them that I've worked with.
All you would need is a computer, internet connection, and a camera and sound. That's it.
And privacy.
Right. And a room, a dedicated room.
No, they would, I think they would do that, especially if they got something back from it. And it would be
camera,
obviously we would be winning for it, but
the computers are cheap. The cameras are $100.
yeah, no, I agree.
It's not a matter of cost. It's a matter of, is the government going to let you go in and do that? That's the issue. And I think Sally,
it'd be like doing it at home. I mean,
right.
You don't have to have it'd be like doing it at home. It would just be that's what it is. You'd have to, like, the VA has a sort of a unique tunnel that when you set up the visit, you actually lock the door so that the whole internet access back and forth is protected. It's not, it's locked down, but and it uses, I don't know how they do it, but that's how they do so no one can come in, no one can storm into it or bump into it or anything like that. But I think it would take some thought, but I think that there are these neighborhood, Jim looks like he might say something there. He knows the neighborhoods.
I was just going to say there could be a lot of possibilities. I mean, with libraries, with rec centers, there's a bunch of rec centers that are distributed widely through the city. Settlement houses. I mean, it seems like a great idea, actually. I actually had a question, and maybe this might be too related too much to COVID, but in my effort to try to be a good citizen of Lakewood where I live, I sort of tap in and follow the social media general websites for Lakewood. And I remember back in late spring, there was a lot of social media chatter about individuals who had gotten tested or gotten some sort of service. And I believe they were COVID related. So this might be particular to that. But the chatter was around the unhappy surprise that a lot of these individuals as patients got when they found out they had been billed for, it might have been a follow-up phone call or some sort of communication like that with their healthcare provider. And I was just curious if you've run into that issue as well, in terms of the degree to which patients recognize that this is, in principle, it's a billable service. Is that clear to patients? That sort of thing. Because it was really striking on these social media websites. It got a lot of chatter.
So that I think I'm probably a little bit insulated because I have no social media account. So I bet I'm insulated to that. And I'm sure what happened last year was when I was seeing you over the internet or a telephone call that I'm thinking, well, I'm not going to get paid that much, but you're probably thinking I'm not paying you at all. So I don't know because, like I said, I have no social media account, so I don't really know what's out there.
Yeah.
But that's my hope is through this last year that all this changes and that the government and the insurance, this is important, that the insurance and should say, hey, telemedicine services are widely available and billable and reimbursable. And I think what happened, it's the same thing happened with patients. I didn't realize how much had been done in the last 15 years. And I'm in telemedicine. The patients certainly didn't realize that, any interaction with a physician, you're going to get paid for. For instance, the e-messaging, follow my health, the store forward stuff, I can envision a day where you're going to have, 5 PAs talking to Dr. Stroll, and he's not seeing any patients, and he's just, managing all these patients at one time. And that happens to some extent now. I get called by the ER and I get paid a call stipend, but I'm available all the time to do telephone consults, right? Or over the iPad. So I think it's just a matter of patients they're only ever used to seeing their doctor in person. And that's really what happened. It was I think the pandemic was probably the greatest thing for telemedicine that could ever have happened.